Susan Pedrino, who you can see on the screen, is also an internist psychiatrist. And Jeff Rado, whose name is on the screen, but who's not showing his picture, is an internist psychiatrist at Northwestern. Susan is actually at University Hospitals in Cleveland. And of course, Steve Melek is an actuary at Milliman. Steve and I have been working probably for 15, 20 years in helping people think through the process of integrating medical and behavioral health services. I started my career at the University of Iowa, and like what Susan's doing now, I ran a med psych unit. She now just has recently started med psych unit at University Hospitals in Cleveland, but has been involved in collaborative care before that and a variety of things. And of course, Jeff has his sort of areas of expertise and activity that he's involved in. So for those of you that are on the call, Patty and Kim asked us to share thoughts specifically about integrated care, but with a special emphasis on the cost impact of segregated care and sort of how that fits into, if you integrate, can you recover any of those costs? And that's what we'll be addressing today. Now, I'm just going to give the background where we are today, what our health system looks like, and et cetera. And then I'm going to turn it over to Steve, who is going to talk about a number of studies that he has been involved in and or published on, and really captures, I think, in a dramatic fashion, the major cost of segregated care in the US and frankly, internationally, as we have it today. And then at the end, Susan will share with you all thoughts about what kind of models of integration are reasonable models to consider moving forward to change the outcomes for the patients that we care about. Steve or Susan, do you want to say anything before I launch into this process?
I'm ready to go.
Yep,
Okay.
likewise. Glad to be here. Thanks for the opportunity.
I should tell Herb and Cy that you should interrupt us at any time during our presentations, because we prefer to answer the questions that are important to you so that they don't get passed by and then forgotten as we move into other content area. We only have about 25 slides, so it's not a lot. We should have time during the hour and a half that we have together to answer all the questions and sort of bring you up to speed on, what this transition from from segregated to integrated care is all about. So Patty, do you have the slides? Can you share those?
Roger, does she have the latest version?
She does. I sent them right after I talked to you.
Oh, okay, excellent.
There we go. Okay. So I'm responsible for talking about the current system. Now, this is really sort of a simple slide, but it really captures the way that our health system works today, and frankly, many international health systems work. So there are purchasers, and those are usually businesses or government agencies. Some people buy their own, but that's relatively few people. But the purchasers then purchase medical insurance and behavioral health insurance. And the thought is that since insurance companies oftentimes own the behavioral health, that they're buying both the medical and the behavioral at the same time. In fact, it does occasionally happen, but more often than not, the two are actually separate contracts. And frankly, I know that because I worked for several years for Blue Cross of Minnesota, and I was involved in the contract negotiations and et cetera. And Blue Cross of Minnesota owned its behavioral health subcategory of payment for care, and it was as separate as if it were a carve out. And so I just want you to know that there are two contract negotiations that typically take place. And it usually is with the health plans or the delivery systems. And for medical, it's generally the medical health plans. For behavioral, it's usually a subset of the behavioral health network of providers, or it is a standalone network of providers like Beacon or Magellan or UBH and et cetera. And then of course, the insurers, whether they're medical or behavioral, pay the providers to deliver care. And on the medical side, they're paying the providers technically deliver physical health care, but technically, legally, they're responsible for behavioral health care as well. But that actually goes to a separate group of providers that practice in a completely separate setting. And if you can give the next slide, Patty. So this is sort of what it looks like. So there's a behavioral health sector, and that's a small sector out in care delivery land that takes care of about 30% of behavioral health patients. Now, when I first got into this, now I'm an internist and a psychiatrist, and so I'm interested in these comorbid patients. I found out that 70% of patients that have behavioral health conditions refuse to go to the behavioral health sector. There are about 30% that will go to the behavioral health sector. The remainder stay in the medical sector. And oftentimes they're treated in the best fashion possible by their primary care or specialty medical providers. But most of the time they're not treated at all. And that's about 60% of the 70%. And so the vast majority of patients with behavioral health conditions don't get treatment for their behavioral health illness. And as you'll see when Steve starts talking, that impacts the cost of care because they use an awful lot of medical services as a result. Now, a certain small, well, it's not a small portion, it's about 80% of behavioral health patients will have a comorbid medical illness. So they slot into the medical sector periodically to get their congestive failure or their pneumonia or whatever treated. Next slide. And so this is what it looks like. So there's a medical sector delivery system, and that's all of the physicians and practitioners on the medical side of the equation that give care in their hospitals and their clinics. And so you have, of course, all of the behavioral health patients, those are the red patients, that don't ever go to the behavioral health sector in that, but you also have the 30% of behavioral health patients that come over to the medical sector periodically to get care. So essentially all of the behavioral health providers, except for about 5%, are basically required to practice in the behavioral health sector. And the reason for that is actually very simple. And this is something that I learned when I worked at Blue Cross of Minnesota and have confirmed with numerous contracts with health plans. They don't want to, the behavioral health payers don't want to pay the facility fees on the medical side. And so they require their behavioral health providers to practice in the behavioral health setting so they can protect the dollars that they have, which frankly are relatively few. And so you have this non-communication, different EHRs, separate physical settings in which behavioral health is provided and the medical sector in which the rest of medical care is provided. Next slide.
The other thing that I've noticed, Roger, is that the credentialing for the behavioral health providers is only in that behavioral health setting, that oftentimes licensed mental health providers aren't credentialed if they do practice in a medical setting. Would that be accurate?
Absolutely correct. They don't get paid, they don't get credentialed. And that's one of the reasons why primary care docs hire basically social workers or other behavioral health providers and not psychiatrists, because they don't want to have to pay the big bucks for psychiatrists even though there is value to having psychiatrists working with the social workers and psychologists, um, because the behavioral health payers don't pay for services provided in the medical setting. So this is just sort of a summary slide. Integrated care really can't be delivered in a divided system as we live in today. The behavioral health providers are not paid in the medical settings, yet the majority of behavioral health patients are actually seen only in the medical setting. Synchronous and coordinated medical and behavioral health service delivery is logistically impossible, and that's the way that the behavioral health payers prevent the behavioral health professionals from working with and in the medical setting. And then medical and behavioral health providers rarely communicate with the medical providers because they work really in a setting in which relationships are not built, and their patients are seen in a completely different area. So that's the last really major sort of background slide. And I think before I go to the next slide, I'd like to answer any questions that people might have.
Do you think that contracting is going to change here in the near?
Well, contracting, I mean, it's interesting, the number of Medicaid programs, statewide Medicaid programs that have gone to a single dollar for both medical and behavioral health services is really pretty substantial. It's like somewhere around 18 to 24 states now have a single budget for medical and behavioral, but because all of the other insurers don't combine the medical and behavioral health providers continue to practice separately because they don't want to lose the income from the behavioral health payers that pay only in the behavioral health setting. And so it sort of has to be a two-way process in order to be successful in this. Does that make sense?
Yes. But that isn't going to impact what the best actual method of delivery of care is going to be, correct?
It only impacts it in the fact that behavioral health payers tend not to go where they're not paid.
Right. Well, that's my point, is that if you were a Martian landing, and said, okay, how would you set up the care delivery? You wouldn't segregate them on the payment model.
Absolutely.
Yeah.
And that's one of the reasons why, sort of as we've started, I mean, I've been running this, sort of my section of the company for a long time, and Steve has worked with me on a number of contracts. We'll talk about that as we get toward the end of the presentation.
Thank you.
So the next slide is actually sort of introducing Steve. Steve and I did a contract with a large insurer probably 7 or 8 years ago. And we always ask for the data that they have related to the population they serve. And this particular insurance company covered literally millions of patients nationally. And this is represented, this slide represents data from about 3 million of their significantly larger million covered lives, and shows really sort of what happens with patients that have various kinds of chronic illnesses. So the top line there is the all insured. So as back in 2014, 2,900 for the all insured. And then if you had a chronic illness like arthritis, asthma, cancer, diabetes, et cetera, it doubled or tripled the total cost of care. And most people don't recognize, but if you just add a behavioral health condition, this does not have to be a serious behavioral health condition. It can be low-grade anxiety or depression or what have you, onto the chronic illness, it doubles the cost of care again. So it's about 3 to 4 times the total cost of care for patients that have just a straight chronic illness. And so Steve and I worked on this contract, and I'm not going to talk about how it panned out, but I'll turn it over now to Steve, who is sort of the financial business person, and he'll share data from a number of things that he's been doing over the past several years. So Steve, I'll give it to you.
Okay, thank you, Roger. Patty, could you go to the next slide? So I'm an actuary. I've been with Milliman for over 30 years now. Started out working for a few health insurance companies, but then determined that I wanted to give consulting a try, and it has worked ever since. And out of those 30 years, probably 25 of them, I've been in the behavioral healthcare space. Started out a little bit of dabbling, but now it's almost everything I do. And of course, as an actuary, you're going to see a few numbers from me because I work on the financial side, whereas Roger and Susan are on the operational and clinical side of things. So I think together we kind of cover the different aspects of the triple aim pretty well. So I don't know if this is a problem or an opportunity. It depends, I guess, on the way you view it. These numbers would suggest both. It's a problem and an opportunity. So kind of like a wreck. What are these numbers? These numbers are results from a national comorbidity survey on the percentage of people in different categories that received minimally adequate treatment. Let me say that again, minimally adequate treatment. So you should be on your psychotropic drugs for a certain amount of time. If you're getting psychotherapy, a certain number of visits are required. So this was an outpatient survey. So the 48.3% represents the percentage of people with mental health conditions that were treated by a behavioral specialist, the percentage that received minimally adequate treatment, about half. Not bad, but why isn't more? Well, patients get in the way. They stop going to treatment. They stop taking their drugs because of side effects or whatever it is. So that's the best number on the page. What's the 12.7%? That's minimally adequate for people with mental health conditions that are treated in primary care. Number goes down quite a bit. It's a fourth of the success rate of specialists. The bottom two numbers are equivalent numbers for behavioral specialists and primary care docs for substance use disorders. So even the specialists can only get minimally adequate treatment for substance users about a third of the time, and primary care, you're 1 in 20. So problem, yes. An opportunity, I think, absolutely. Next slide. So there's a lot of comorbidities, as all of us know, with chronic conditions, and here's a handful of them: chronic medical conditions and mental health and substance use disorders. And this is not a chicken or egg issue. One could lead to the other. You could start out with depression, and then that could lead to obesity, physical pain, maybe diabetes, or vice versa. Chronic medical conditions, if you're not doing well with your chronic medical condition, that could lead to a substance use issue or to anxiety or depression. So the point is, there are in the range of 10% to 50% plus of these comorbidities present. So if you have a chronic medical condition, there's a good chance you might have a comorbid behavioral condition and vice versa. Next slide. So now I'm going to talk about cost impact and savings opportunity, because I believe there is a tremendous opportunity for people that are unaware or have not integrated care in behavioral and medical conditions. Next slide. So we did an analysis of a large database of Milliman's proprietary data that we get from a lot of health plans and other payers. And it represented about 40 million people. So a little bit bigger than Roger's example from the one plan that we assisted. And we had commercial, Medicare, and Medicaid populations. And we divided the populations into 4 cohorts. They had no mental health or substance use disorders based on the claim data. So we're looking at diagnosis codes and CPT codes, DRGs, evidence of a behavioral condition. Cohort 1, there was none. And then the other 3 cohorts are non-serious and persistently mental illness the SPMI population, so the two different less severe, more severe mental illness conditions and substance use disorders. And we had all claim costs, so we could separate it between medical and behavioral. And we also decided to slice it between medical services and prescription drug services. Next slide. So this is a little busy, but you can see we've got chronic medical conditions, and these are just the ones we selected based on prevalence rates. That's in the first column, and going across, and this is for the commercial population. You can see the per member per month costs. As actuaries, that's kind of one of our standards is per member per month cost, the PMPMs. How much the rates are going to be for people, how much their costs are, et cetera. So we've got no mental health or substance use disorders found in the claims data. Again, the disorders could be underlying, but just there's no evidence in the claim data. And then you've got the three different behavioral condition categories that I just described. So let's take asthma, for example. The average person with asthma, as in 2017, cost a bit over $800 in healthcare costs PMPM. That's medical and behavioral costs if they had them, total costs. Layer on a SPMI disorder or a lower grade mental illness or substance use disorders, and you can see how that $800 goes up by $1,000, $1,200, $1,300. It really goes up quite a bit. And condition by condition, you can go down to chronic pain, hypertension, liver disease, et cetera. And we've got no medical conditions or any medical conditions, these chronic medical conditions summarized below. You look across the whole population, the average member that's insured in a commercially insured plan cost $426 PMPM in 2017. And once you get a behavioral comorbidity, that jumps up by, on average, a factor of 2.5 to 3 times. So this is an opportunity because we're spending so much money on people that have these combinations of disorders. So let's look at some more numbers. Next slide. So if we break it down, again, these are the populations. You can see commercial, Medicare, Medicaid. Maybe I'll just go to the totals at the bottom. And we've got the medical and behavioral components and the prescription components that I described. And then there's member months there, so you can kind of see the distribution of the members that we had. But for people that did not have evidence of a behavioral condition, their total cost, $525 across Medicare and Medicaid population in our database. If they did have one of the mental health or substance use disorders, on average, that PMPM cost goes up to $1,400. So, well, of course, they're going to spend more on the behavioral side. We had very low, as you would expect, behavioral costs if they didn't have a diagnosis code attributed to it or it wasn't a behavioral service. But you can see we're spending about $250 out of the $1,400 on their behavioral services if they had a mental health or substance use disorder condition. But what I want to point out is how much the medical costs go up when you have a comorbid behavioral disorder. 425 goes up to 923. 90 of the prescription drugs goes up to 230. So why is it? Why does this happen? It's the exacerbation effect that a behavioral condition has on your medical condition. So if you've got asthma and you're also depressed, you might not be taking very good care of yourself for your asthma, for your diabetes, for your heart condition, whatever. So you end up spending more time in emergency departments. Your hospital stays could be longer. You could have higher readmission rates. And I define that as the value opportunity. The difference on the medical side, I'm not saying reduce the behavioral spending, although you could argue some of that behavioral spending might not be really effective, as we saw on a previous slide, but the medical costs are going up significantly because of the interaction of the behavioral condition with the chronic medical condition. So my suggestion or hypothesis in this study was that The differences on the medical side represents the value opportunity. That's my definition in term. It's value opportunity for integration. So if you can deliver better integrated care so that the persons with comorbid chronic medical conditions and a behavioral condition or multiple behavioral conditions, if you can treat that behavioral condition better, you can reduce the medical spending for those people because of the exacerbation effect of the behavioral condition. So the next slide takes these PMPMs and grosses it up for the entire population. So again, this is 2017 spending. These are millions of dollars. So again, you look down at the total. We just looked at the prevalence of mental health and substance use disorders on the previous slide, and about 15% of people had some sort of a treated behavioral disorder. But this shows in this slide that about a third of the cost of the total cost of those people are for those with mental health and substance use disorders. So you can see the opportunity here is very large. There's medical spending and medical RX spending of $1.2 trillion for people without a disorder, but $508 billion of spending for people that have comorbid substance use disorder or mental health condition. So what we're looking at here for a cost impact is how much of this excess medical spending that is possibly preventable with better treatment of their behavioral disorders can be saved through effective care programs that are integrated. Next slide. Oh, so this is, again, if you wanted to isolate one of the medical conditions, for example, asthma, and this is in the commercial population only. This slide is just showing an example of we're spending and this is annually, $6.7 billion for patients with asthma and an SPMI, $15.5 billion for non-serious mental conditions, et cetera. So this is just giving you more data because I wanted to show you data on what the cost would be when you extrapolated to the entire commercially insured population in 2017 dollars. By the way, we are doing an update of this study by the end of the year or early next year, hopefully. Next slide. So what programs have worked? How do we know how much we can save? These are just some examples of what has worked on these smaller scale attempts to do integration. And I would love to have more larger scale approaches. And I will talk to you about one that we did in Colorado. But the diabetes and depression program, multifaceted one, MDDP that was called, and the Pathways program showed that you could save somewhere about $40, $45 per member per month. So that's pretty good. It's about 5% over 2 years. The Impact program for depression with the elderly, about 10% of their healthcare costs. Joe Park's Missouri community-based mental health care health homes in 2012 decreased overall health costs by 8%. So in total, I identified the excess medical costs as the savings opportunity. These savings of these effective programs, it's key, it's got to be effective, but if they are successful, you can save between 9 to 16% of that savings opportunity. 9 to 16% of the excess medical costs can be reduced through effective integrated care programs based on these program examples.
Could I ask on the just looking at some of the additional information you have there on the Missouri health homes, I would interpret the independent living increase by 33% and the vocational activity increased by 44%. I'm not sure what the specific metrics for that were, but there's certain intuitive ones there. Those are profound differences as far as the quality of life. Am I correct?
Yes, yes.
Because I know when we talk to actuaries, they tend to talk numbers and money.
Yeah.
But this is something that I don't think is lost on CMS and the Medicaid programs, is that type of an outcome, even if you're talking about the same amount of money.
Right, right. Yeah, I'm focusing on like one element of the triple or quadruple aim, whichever one you like to use. But you're right, improved clinical outcomes in health, patient satisfaction, provider satisfaction. You can't really put a dollar number to those easily. It's easier to put dollar numbers to how much healthcare costs were avoided, which is what we're doing here. But those other elements are super important as well too. And I'll talk a little bit more about that in another example in about a couple
Thank you.
minutes. Sure, sure. Next slide. So if you take that savings opportunity and you take that 9 to 16%, how much money are we talking about in a year across these commercial Medicare, Medicaid populations in the US? Big numbers, close to 37.6 to $67.8 billion a year across the entire US population. If we extrapolate the results from our analysis to the entire population nationally, that's how much opportunity is on the table. That's a lot of money. And I know it can only be scratched into with effective programs in pilots or other kinds of opportunities where you can integrate care. And as Roger and Susan would say, this is integration across the full spectrum of healthcare, inpatient, outpatient, emergency, pharmacy, et cetera. But $38 to $68 billion per year is what the opportunity would be if we could effectively change our entire US delivery system and tap into that 9 to 16% savings that effective programs have shown. Next slide, please. So we talked a little bit about contracts, and these are my opinions. They don't maybe necessarily represent Roger and Susan's opinion, but my opinion is fee-for-service is not going to work for integrated care. You can't just ask a primary care practice to start paying the salaries of the behavioral providers that you want to integrate in there. Some might be able to do that, but fee-for-service in primary care, just shoehorning providers in there probably is not the way to go. There's an administrative burden at adding more fee-for-service codes. The new models have to incorporate the objectives of the triple aim. Good data is very important, and buy-in from all the parties and some of the experiences I've had is super important too. Otherwise, it's not going to work. Next slide. So here are some suggestions. You could do primary care capitation plus add in the behavioral services that you can provide in a primary care practice and do a combined capitated payment, a per member per month payment. And you can add in the care coordination and management that goes with it. It's got to be population specific, certainly, and risk adjusted. So you get the right kind of payments for the right kinds of risk levels in the population. You can have options depending on the types of behavioral providers you're incorporating. Is it social workers? Is it nurse practitioners? Is it psychiatrists on consults, telephonic consults perhaps? Psychologists, part-time, full-time? It depends on the way you're doing it. I'll say a little bit more about that in our next model. Risk sharing or gain sharing for the services outside primary care would be, I think, essential. If you're going to save money for the health plan, I think the health plan should share some of that savings back to the people that are generating the savings by doing effective integrated care. And of course, it's going to vary depending on what of the services you are implementing integration. Is it inpatient services, outpatient facility services, physician, primary care, pharmacy, et cetera. So again, these are my opinions on some of the payment model reform ideas that I like to suggest. Next slide, please. Okay, so now the last thing I want to talk about is our Colorado SIM project, State Innovation Model. The Centers for Medicaid and Medicare and Medicaid Innovation made money available to applicants for different kinds of innovation models. So the state of Colorado put something together, and it was actually a combination of our healthcare policy and financing group and our environmental group. They put an application together, sent it in to CMMI, and CMMI said, this integrated care idea of yours, and it was a primary care integration project. It's a good idea, but we're not really fans of the proposal you put together. So here's what we're gonna do. We'll give you $2 million to go do it over and get some support. So we got hired to provide some actuarial support, and we did projections. You know, I think their initial submission had an ROI that was, you know, in the atmosphere, thousands and thousands of percents of return. And it's like, oh, that's crazy. You're a little optimistic there. So we asked for $87 million. They turned around and granted us 65. So we projected an ROI through 3 years of program implementation. They also asked us to do it through 4 years to get 1 year after. But we started with a 1.46 ROI, which I thought was a whole lot more believable. And that turned into 1.95 when they cut the amount we could get up to $65 million. So essentially a 2-to-1 ROI was our target through the 3 years. We had 1 year to ramp up. They called it the pre-implementation year. And then we had 3 years of implementation where we had primary care practices apply. I was not a part of the application review. That was at the university and at HCPUF. But we were targeting to get about 250 to 300 practices applying. And we also had a handful of community mental health centers, 4, that did the reverse integration, if you will, putting physical healthcare into the community mental health centers. So we had 3 phases of applicants in each year, one in year 1, one in year 2, and one set of applications in year 3. And let me show you the results. Next slide. Because we started this in 2005 and 2015, and it ended in 2019. Get my decades mixed up here. So we were projecting and expecting reductions in costs for inpatient services, including behavioral. We thought that some of them may not have been necessary, ED, ambulance, SNFs, but we were going to increase costs in professional services, diagnostic testing, some labs, prescription drugs, because people were non-compliant on drugs they should be staying on and stuff. So the projected savings by year of the program, year 1, year 2, year 3, which would have been 2016, 17, and 18, was a total of $126 million. The calculated savings, and this literally never happens, was almost an exact match. But what's interesting was the pattern. So we beat our projection in year 1. Now, year 1 applicants were the cream of the crop. The way they were accepted were, they were literally already doing integration to an extent, but the different supports that they got were to help them do it even better. In year 2, we did not have a cohort of practices that knew what they were doing. So they took a year to figure things out, and they actually ended up spending more than we thought that they would. So we had a negative return, if you will. So combining success of cohort 1 with the lack of success of cohort 2 in year 2 showed a loss. We actually ended up spending more money than we projected. And then year 3, we ramped everybody up better. We exceeded our projections, and we caught up with how much we lost in year 2. So we almost matched our target of a 2-to-1 ROI. And this, again, was a primary care integration model. And we did not tell them how to do it. would let each of the practices determine clinically, administratively, working with the payers in contract changes, which was secret. We did not get involved in any of those negotiations, but we essentially let them figure out the way of integrated care that was going to work best for them. Because in Colorado, we have urban, rural, and frontier areas where a lot of ranchers, very low population areas and stuff like that too. So some used a combination of telehealth, face-to-face health, and this is all, of course, pre-pandemic. So, and I think that might be my last slide. Next slide. Yep. Now go
Refresh my
forward.
memory on the total spend in that population there, that the savings was 125.9 million calculated. What was the total spend that was the savings out of?
Oh, that's a good question, and I'd have to look that up for you because I didn't put it on the slide. So maybe while Susan,
Thinking of back calculating, you were saying that the ROI was approximately 1 point something, and I was just trying to get a.
oh, I see. The grant funding that they gave us, if you can go back one slide, I think they gave us up to $65 million. Yeah, and we didn't quite hit the $65 million. So the avoided healthcare cost was about double the grant funding. So we paid for their grant and twice over through healthcare costs that were avoided. So what percent of the total healthcare costs of all those patients are, if that is your question, I have to look that up while Susan's presenting.
Well, still, that actually gives me the sense of where I want to go with what your return was on that, because the scale of it is helpful.
Yeah, essentially what we showed is that you'll save twice what you invest. And this was only implemented in primary care practices and a handful of mental health centers. So they were not responsible for changing the way the emergency departments were staffed or inpatient services were provided. They might have influenced some of that, but their main responsibility was to do it in their primary care practices only.
Yeah, no, I mean, I'm delighted when I save 5% over what I spent. So
yeah, that's real money.
Yeah, very good. Thank you.
Sure. Susan?
Sure. So thank you. I think Roger and Steve have really made the case for some of the ways that integration can provide an opportunity for cost savings. Actually, Patty, can you keep going with the slides? Sorry. And I apologize, I'm appearing in the meeting twice because I had to switch devices. I'm gonna have to hop off at 5 o'clock because I'm hosting a webinar for the women faculty at CASE, and I need to start the webinar, but then I'll be able to hop back on. So if you continue to the next slide, as I said, Steve and Roger have sort of made a compelling case for the importance of integrating at the level not only of providers and patient care, but of the importance of integration from the level even of purchasers and payers, vendors, even regulations need to be in consideration of a more integrated delivery system so that patients can access the care they need for both physical and behavioral health conditions where they go for care. Can you go to the next slide? This is a reimagined integrated system, so-called simple, where patients with both medical and behavioral health conditions, I think a lot of the people in reality are purple, not red or blue, but they can access, as I said, the care that they need where they go. whether they go to see their primary care provider or they present to the emergency department, that their need can be identified and managed and directed to the proper place. Okay, next. So there are many opportunities for integration. There is always the question of what steps do you take? What do you do in your own system? What do you do first? How do you know what works? And many people are familiar with the collaborative care model, which is one very effective method for integrating behavioral health into primary care. But there are many, many different models that can help bring care for patients into the medical setting, and which may be appropriate for your setting, your system, your hospital, your providers. And it really depends a lot on local context, local resources, and what are the goals for the care? What are the populations that you're trying to serve? What are the needs that you're trying to meet? There are opportunities in the inpatient setting. You may have heard about proactive psychiatric consultation, but even delirium prevention, reviewing sitter or direct observation requirements, all the way to complexity intervention units, which is another name for med psych units, which, as Roger mentioned, is one of the things that I do at university hospitals, is lead their med psych unit. And then in the outpatient setting, these are things that are maybe more familiar, but bringing medication-assisted treatment for alcohol use disorder or opioid use disorder into the primary care setting, where those patients are often found, can really make a tremendous difference. The emergency room, and then another important area that a lot of times medical providers aren't as familiar with or don't have as high on their radar is case management. And there is a evidence-based approach to integrated case management that allows for real impact on the most complex and in some cases, the most high utilization patients within the system. And then I would be remiss to not mention that you would, of course, need to continue to have this specialty behavioral health setting for certain specialty services, such as ECT or, patients with severe mental illness. Just like any other medical specialty, there's a need for subspecialty care and subspecialty settings. So go on to the next slide. And I think we lay out for you some of the return on investments from the published literature and some of our experience with other health systems. As you can see with the value-based integrated care management, there's a return on investment approximately 9-to-1. And then other interventions are not as routinely robust, but it depends a little bit on the style or the method of delivery and the exact setting. But these are all very powerful interventions, not only to improve care, but also to reduce the cost of healthcare. So at the bottom of the slide, you'll see the type of savings that you can expect from a med psych unit, for instance, or from including behavioral health, the availability of behavioral health assessments in a medical emergency room, with lower costs resulting in fewer admissions and greater ER availability, things like that. Okay, next slide. I think that might be my last slide. Okay, so now I'll turn it over to Roger and Steve again.
Okay, so thanks, Susan.
Well, I guess we should ask, are there questions?
Yeah, right.
About those?
No, I'm good. Thank you.
Steve,
I do have the answer to the question of if the question was what percent of healthcare spending did our Colorado SIM project save in the aggregate, and this is across the Medicare, Medicaid, commercial populations, CMHCs and the primary care practices. Those that did it well, those that did not, in total, we saved 1.7% of total healthcare spend. That's not too bad.
Thank you. That's helpful.
Sure.
So are there
Questions?
other questions up to this point? I mean, at this point, I guess we're working with Patty because there's interest in considering doing integrated service delivery. And of course, there are quite a significant number of models of integrated service delivery, and we've been doing this for some time. Certainly the most common is collaborative care, and that was started at University of Washington and has spread, frankly, internationally and is used in a large number of locations at this point. But there's proactive consultation, there's complexity intervention units, there's behavioral health professionals in medical emergency rooms, not in standalone psychiatric emergency rooms, and et cetera, all of which bring value to the patients. And so Cartesian Solutions and Milliman have partnered to provide assistance to those that are interested in doing this. It really runs in 3 phases. The first is an assessment of the organization's current clinical and cost situation. If there's interest in being focal, in other words, I have started a number of med psych units around the country because they were interested in doing med psych and other locations that may be another form of integration. We frankly like to look at the big picture because you're dealing with services to a population, and what you would like to do at the end of 3 to 5 years is have services that are integrated across a number of clinical areas. And that's sort of what we do. So we work with the organizations to create an integrated implementation plan for the variety of services that bring value to patients and the health system. And then we assist the organization in documenting during the implementation, but also in measurement of health and cost outcomes. So we work with local professionals to help document the value that you're bringing, sort of like Steve did in the CMMI project in Colorado. Steve, do you have any comments?
Not at this point, no.
Okay, and so the last slide is really just our names and email addresses and Patty's, and she will share this with the participants in the webinar today. But we're happy to answer any questions because we've covered a lot of material, really focused quite a large amount of the information on the cost savings potential. But there's a lot of things we didn't cover with regard to, how to put together the various kinds of integrated programs that are value-based, and et cetera. So I guess I'll open it up now to questions or comments or what have you.
Yeah, we'll be, we've been recording this and we will be sharing the PowerPoint slides. And I see Dr. Macias, I don't know if you're still on or you were able to chime, if you want to chime in and say anything about your role.
Yeah, I'm here. I've been listening in and learning about this. I'm trying to establish a psychiatry residency program in a large healthcare system here in Arkansas, and I'm working with Dr. Gibson, trying to get her become part of my faculty member group, because I would like to have a program that starts with all these different approaches, so the residents will learn collaborative care, they'll learn integrated behavioral care in primary care settings, and they will also learn the traditional psychiatric training that they need. So I don't know if you guys ever came in a situation like this to think about coming in the system at this moment in particular.
Yeah, I mean, if you're interested in developing training programs for this, I mean, there are 3 of the people that are on that are internists and psychiatrists. So we went through both medicine and psychiatry residency programs. They're pretty easy to start, and they bring a lot of value. And it's not just in patient care and teaching, which is quite profound. I mean, I ran a combined program for quite a bit of my career academically, and there are a lot of jointly trained people now, neither of which are Susan or Jeff. But it is an area of opportunity, because then the people that you train can train others.
Right,
You
right.
can train the straight medicine residents or straight family practice residents, others, straight psychiatry residents, and et cetera, and medical students, and et cetera. And so it's sort of, I mean, I know at University of Iowa, which I spent 25 years working, now has a robust integrated perception of care.
Yeah,
Yeah.
and that's why I'm bringing, I'm trying to get Dr. Gibson to be part of it from the beginning, so we can think about this together. And so I appreciate the opportunity to learn from this presentation today. Thank you.
Okay.
Thanks for joining us.
So obviously, Dr. Gibson's the obstacle that's standing in the way of us actually being able to do this, right? Could I ask, one of the things in Arkansas is an any willing provider state, and it does, there are problems when you're trying to have network integrity, to where you have a health plan that is able to actually deliver this kind of care, but in order to be able to structure the delivery model, it isn't everywhere, it's only in certain places, and trying to keep the patients herded, as it were, into the place where the care is actually going to be optimal. It becomes really hard for us unless it's a model like a managed Medicaid model, or a model like a Medicare Advantage plan that has a built-in narrow network that is permitted by other regulations. I think here in Central Arkansas, it's going to be doable for us to be able to work with collaborative commercial payers to work on that kind of, if they knew that this kind of result could be delivered, but they would only anticipate it being delivered in a model structured the way you've been describing in one of these, because even though you described a number of different models, they all had a lot in common, that as far as the integrated care. I think that's going to be one of the things that I'll be talking with Patty about, is where do we get a large enough patient population that has the demographics that you're describing. Well, and of course, any patient population that's big enough is going to have the overlaps that you're talking about with the behavioral health component and the physical health components. That's not a problem. That's just humanity. But as far as us being able to be in a position where there's actually actuarial risk for the providers in order to be highly incentivizing for executing on this, I think we're going to have to talk about where we can create that. But I think Patty knows Dr. Tyler and myself well enough to know that we actually work in environments like that, and then it'll be a question of how do we model it. And then, of course, it would be wonderful to have it as part of a training program, because then you have providers that come out already. We tend to practice the way we were trained. And if you come out training in an archaic model, you're going to be resisting the new thing. So
the next for the next 20 or 30 years.
Right.
Or more.
Or however long you live. Yeah. Yeah.
All right, it's 4 o'clock, so I have to go off now. I
Thank
really
you.
appreciate you guys, and Patty, I'll touch base with you later.
All right.
Thank you.
Thanks for joining. Take
Bye.
care.
Thank you.
One of the things too, just looking at systemic issues, Dr. Hahn, is what I saw mostly working in primary care. You know, those primary care providers are incentivized to decrease their ER visits and hospitalizations. But if the hospital, you know, there's kind of conflicting motivations. And so I think that could be some of that when Steve's talking about a fee-for-service model. As long as we're all being paid for what we do, then each group is going to need to do what they do. So whether they be the ER, the hospital, or the primary care clinic. So I think that's something in terms of a whole system savings. It's going to have to be utilized. And so looking at the data, since I was mostly in primary care, I focused on that. But then seeing all that return on investment when you just by putting mental health providers in the ER in some fashion. Delirium prevention, that's huge. And I know we have consult liaison psychiatrists in most of the hospitals, but it's sometimes hard for them to get around, and it's not an afterthought, but it's not an intentional, proactive plan. So there's some places that there could be some real cream off the top that we haven't been paying attention to on the inpatient side.
Well, and Patty, you're making a very important observation in that when you're talking about a hospital and a hospital system, and I still refer to us as a hospital system, not a health system, because it is a fee-for-service structure. The minute you start talking about decreasing unproductive or unnecessary spend by taking better care of people in the appropriate setting, you're talking about decreasing spend. Well, that's somebody's income. And in a fee-for-service model, a lot of that comes out of the hospital. A lot of, you know, an ED that has more capacity than it's using wants more utilization. And so we're not singing a good song. We're trying to, like right now, we're involved at the CIM, we're involved in conducting the bundled payment care improvement initiatives that the hospital benefits significantly by the efficient care of patients, but that's mostly in the post-acute setting. And so we're not taking the payment that they get from CMS out of their pocket. It's out of the SNFs and the rehab hospitals and stuff like that. So we're able to get the cooperation, but at least they're understanding how the efficient use of scarce resources can be appropriate as far as saving money. But this is just simply much better care, and that's going to be a hard one to argue against. That was why I was actually calling out some of the even bigger benefits to the patients. And I can tell you, my background was orthopedic surgery, and the fact that people would say, well, you didn't diagnose depression here and everything. The heck I didn't. I was just that I didn't have anywhere to make a referral for the patient to get treated. And that was true with a great many things. The same thing was true for substance abuse. As an orthopedic surgeon, I was just, and also my period of practice was during the time when they were also holding us accountable for not treating, legally not treating somebody's pain, so we had the double whammy. And I just think that really at a time right now, our system is intending to very ambitiously take on creating a comprehensive enterprise-wide public population health services organization that this is going to be one of the key integral parts of. And I think that's why optimistic that Dr. Tyler and Dr. Choate will be able to see this presentation too.
Roger and Steve, do y'all have any comments about how other systems have managed to kind of tackle these conflicting needs?
Well,
Yeah.
I'm just going to add that while I didn't present on it, nor is it my area of expertise, but I was a co-leader of the evaluation work group. We had 8 work groups with our SIM venture. One of them dropped out at a point, but I was a co-chair of the evaluation work group. And in that capacity, I heard lots of presentations and evaluations of clinical outcomes, provider satisfaction, and patient satisfaction, the other parts of the triple aim other than reducing healthcare costs. And they were all favorable, not perfectly so, but in the aggregate, the providers liked it better. Again, this is primary care integration. The patients liked it better. They got healthier. We saved money. So everything was working. I appreciate the challenge of we might be taking money out of some people's pockets here, but if it's the right thing to do, and if somehow that lost revenue can be replaced in another way, maybe it actually isn't lost in the aggregate. But yeah, so we did in Colorado hit on all cylinders there by the end of the program. It was it was sad in a way when it stopped, because all of a sudden everybody goes back to their own, their normal jobs and do what you do. And it's like, oh, the SIM office closed. It's not there anymore. And but hopefully all the practices actually implemented the integration, and through their efforts at negotiating with the commercial payers, the Medicaid program, et cetera. Of course, CMS and Medicare payments were the hardest one to try to negotiate differently. It really couldn't. But, they did put collaborative care codes out there and stuff like that. And I know there's all kinds of challenges with those codes, and how do you break even under that? But they did successfully, I think, negotiate payment changes with commercial payers, and and Medicaid and HCPF were working through some payment changes as well that hopefully we're going to further support the effort after the office closed down last year. So that's what I had to add. Roger?
Yeah, okay, so I'm going to take it a little different direction. Regardless of where you make changes, there are going to be winners and losers. And certainly as healthcare providers, we are interested in the patients being the winners in this. Healthcare providers are going to be some healthcare providers that are going to get paid more, and some that are going to get paid a little bit less, because we're looking at trying to restructure the way that that services are delivered that are more efficient and effective in particularly the complex patients, which many of these behavioral health patients with comorbid medical problems are. The thing that we do is we recognize that there are many ways to, take care of a problem. And so we try to work with the clients to recognize that sometimes you can't do away with fee-for-service in all the areas, but we can create a capitated environment in some subset of the population, et cetera. And then as the health system that is implementing that becomes more efficient and creates new opportunities for the people that are maybe not supported as well, then more changes can occur. The point is that you got to start if you're going to improve the outcomes for patients that are having difficulty in getting better in our system. And that's really what this is all about. I mean, these are chronically medically ill and comorbid behavioral health patients that commonly have poor outcomes as a result of the way that we deliver care. And this is a start in that direction that has many steps to take. We prefer to work with people that are interested in looking at the system. On the other hand, we will look at various kinds of programs independent of the total system and help with those. But in the long run, your system is going to work better if you create a system of integrated care rather than continue to segregate behavioral health from the rest of healthcare. It's just too interconnected.
Well, I think that's our intention, is to actually not try to graft on something, not add on and convert the garage into a game room or something on what was otherwise a pretty good house, but really start out and create a model system in the likely areas where we can execute on that. That was why I was delighted to hear, about integrating that with a training program where we're also going to, have a lot of resources that can be directed to that. But we're going to be in a position to where we're going to be on the other side of the premium, to where a enterprise approach can be taken, so that it won't be simply asking somebody to give up their piece of the pie, but the pie will be appropriately apportioned to the people who are making it all work. And that's why I'm delighted to see that there is actually savings here, because one of my big concerns that I think you all have addressed is I felt like we simply weren't spending enough money on behavioral health, and that at a time when everybody's saying we've got to spend less money on everything, I was saying, yeah, but we've been under providing for behavioral health. Now, in my mind, there's no question that's true. We really do need to budget more for the care of behavioral health. But the first thing we can do is reconfigure the system to deliver the care. That would be the first thing, would be to put the care in the right place, because it would be, I think, foolhardy to devote more resources to behavioral health in an archaic model to where it wasn't going to be effective. But I think we'll be able to do this in an integrated fashion right out of the gate. I don't mean, sort of make it in multiple steps.
That's pretty exciting.
Mm-hmm. Sai, did you want to speak up? Oh, sorry.
Well, we didn't just wake up and think that this was a good idea. I know it's been on Patty's mind for quite a while.
Yeah, I think it's even a better idea with the pandemic still hanging around, and the increase in behavioral stressors, our mental health, people's mental health turns into mental illnesses, substance use going up, suicide ideation going up. I think this is an essential time to provide more behavioral health care services, because the needs are greater and greater.
You make a very interesting point in that here in Arkansas, a lot of people, well, like your point about the fact that people seek care in the physical health realm and are reluctant to go and seek behavioral health care when their main problem is a behavioral problem or a psychological problem, an emotional problem. And I'm not convinced that here in Arkansas, the world of people who think they're normal are getting a chance to shake hands with what it's like to be stressed beyond your limit or right up to your limit, to be feeling like you're psychologically fragile, or encountering that in their family unit, or with things like that. And so I think you make a really good point that right now the world at large is going to be prepared to embrace this idea that we're all of us need this kind of support more than we've been paying attention to.
Totally agree.
Yep.
This is Cy Cox. I just wanted to add a brief piece of information that could be relevant to the conversation here. Dr. Hahn may already be aware of it. Dr. Gibson certainly is. And if Dr. Tyler here, I'm certain he would bring this to point, which is we are currently in a CMS innovation project called Comprehensive Primary Care Plus, which has its own relevant set of rules and payers, and in this case, Medicare is the primary driver, is the driver of that innovation project. In January of 2022, all of Arkansas Health Group's primary care clinics will likely move into the next innovation project, CMS and Medicare, which is primary care first. And what's relevant about mentioning this is that the very first year of primary care first, from January of 2022 to the end of that year, the only metric that is used to determine success from an organizational standpoint, that is for AHG's primary care clinics, is how much have you decreased your acute hospital utilization. That is the only metric by which we will be measured as an entire system. So I'm sure when Dr. Tyler either listens to this, and as Dr. Choate does, and as Dr. Hahn works with those good people in our leadership positions to think about this, that's going to be a significant part of the calculus. I just wanted Dr. Kathol and others to hear that up front, because one, it speaks to the conversation that you're all just having regarding which slice of the pie goes to which part of the organization. But that's obviously a significant consideration from our perspective as we move into the next innovation project.
You know, I think that's a good point. And, you know, as you were talking, I was thinking, I mean, there's a tendency, there are many ways to do behavioral health integration wrong. And there are a number of ways to do behavioral health integration correctly. And that's one of the reasons why Susan shared the return on investment. Return on investment generally means that something was done right to decrease the service use so that there was savings in healthcare dollars. But there are a lot of ways, and in fact, there was 40 years of putting counselors into British primary care clinics that ultimately, over that 40 years, demonstrated in the studies that were done that it didn't work. And so there are a number of things that now we know work, that have evidence of efficacy and cost savings associated with them. And that's one of the things that we start with. We do not throw away things that don't have evidence of efficacy, that have evidence of scientific merit, but we start with the things that tend to work best first, and then, you know, work sort of down the line. So you know, it's how you do it, but it definitely needs to be done. Behavioral health is such an important contributor to outcomes of total healthcare that really needs to be addressed.
Was the British model enough different as far as how providers were paid that it would have not supported the kind of transition we're talking about?
Well, it was, I mean, the GPs in Britain were paid, they were salaried, as, you know, many of the national government systems are. On the other hand, they just hired behavioral health professionals to be a part of the team to do what they wanted and didn't have expectations. And as a result, they certainly were busy and helped out in the clinic, but they didn't bring value to the patients. And so we now have ways of making value. And Steve gave a good example of that with the CMMI project. So we're now in a position where we can do things better than it has been done in the past.
Very good.
Well, I think we could keep talking for a while, but this might be a discussion to have on another day. But I appreciate everybody's showing up and the conversation and the information, and we recorded it and we'll be able to share it, and we'll continue. Does anybody have any thoughts or anything they want to say as we close down?
This
How
is
do you-
Cy again, just very
ahead, Cy.
briefly. Yeah, thank you, sir. Just very briefly, I recognize, and from my work with Dr. Gibson, and as we've moved forward at Arkansas Healthcare, that eventually we have to come to the point where what we're doing and what we're trying has to be evaluated from a financial perspective. So I'm grateful to see that moving forward. And if Milliman and the other organizations, Cartesian, are part of that, I'm happy to see that happen. So thank you for your time today. I greatly appreciate it.
Well, thank you for having us.
Thank you. Yeah.
Patty, you said that you were recording it. Is the slide deck going to be available? Because it'd be helpful for me to be able to memorize and commit to memory some of those numerical things. Because, you know, when CFOs start talking, they're not as interested in my soft answers.
Yes, I'll send you the recording and the PowerPoint at the same time. Because there's definitely some good statistics and good data there, and the evidence is there. And thinking about individual patient satisfaction, and that the individual provider in Britain might have been happy in that individual patient, but did it make a difference for the population? And how much of a difference did it make for that individual patient? So going very micro to macro seems to be a really important piece. And the other piece is involving the payers. They're the ones that also have a huge stake in this, and a lot that they could gain by collaborating with us.
Thank you all very much.
All right. Thanks very much.
Very
Y'all have a
enjoyable.
good
Thank
evening.
you.
Bye-bye.
Thanks.
Bye.
Bye-bye.
Uh-huh.
Be
Bye-bye.
well. Have a good evening.